Hi everyone, my name is Carrie. I'm going to talk through the thyroid dysfunction aspect of your exam. So a little bit about me. My name is Carrie, like I mentioned. I just wanted to say thank you for having me teach you guys about this. I'm not very familiar with the Concordia campus since I went to the Medical College of Wisconsin, but I do look forward to visiting you guys very shortly. I'm currently Pro Healthcare's first class of residents with my co-resident Amrita here showing on the bottom right. But my favorite role is being a wife and a mom for my cute little daughter. So just an informational slide for you as students. Thyroid dysfunctions can be challenging to understand. However, I tried creating a small table for you to fill out as you listen along to my PowerPoint presentation. So in order to be prepared for your exam this upcoming Friday, just make sure to take notes, however is best for you in the tables below. But we will meet again on the 27th to go over case questions I have prepared to make sure that this topic is drilled into your minds for your exam. Objectives are highlighted here, and you can pause this just to make sure you have read them and understood them as we go over this presentation. Just as a side note, I was a student not too long ago, so I know how important it is to fit as much as you can in your minds and to take only the important aspects with you on your rotations. So I don't want you focusing on specific dosing of medications unless I do touch on them. And because we are so blessed with the amount of resources that we have, it's something that is easily looked up. So I would rather have you guys focus and understand the why behind some treatment agents and why we use them. An additional side note, the slides that have a yellow border around them indicate importance regarding the NAPLEX exam or regarding any quiz or exam questions that will be pertinent for you. Additionally, during the PowerPoint presentation, we will come across some medical terms, and in order for you to fully understand and grasp what they mean, I included this abbreviation table. So just as a refresher, thyroid hormone actually represents the combination of the two hormones that are from your thyroid gland, T4 and T3. They're often collectively referred to as thyroid hormone just because T4 is largely released about 80% and it's largely inactive, whereas T3 is active, and once your thyroid releases T4, certain organs in the body transform it to T3, such as deiodinase, so that it can impact your cells and your metabolism. So to start this loop, at the top, the hypothalamus releases TRH, which in turn stimulates your pituitary gland to produce and release TSH to stimulate the thyroid gland overall, and that produces T4 and T3. In order to produce T4 and T3, your thyroid also needs an adequate amount of iodine, which is a substance you can get from the food that you eat for those hormones. So as a reiteration, there are T4, T3. Let's say there are decreased amounts of thyroid hormone that are below normal. The hypothalamus then releases thyroid regulating hormone, stimulating the pituitary to produce TSH, which acts on the thyroid gland to produce more hormones and raise the blood levels. And then once those levels rise, there is an increase in the hormones, and then the hypothalamus kind of shuts off and then stops secreting the RH, and then in turn inhibits the pituitary gland to release TSH. If there are any issues with your thyroid gland, they can result in an imbalance of these hormones involved in the system. So one of those examples is hyperthyroidism. I included the guideline here for hyperthyroidism, which is an optional reading for you. So hyperthyroidism is the overactive thyroid, which happens when your thyroid gland makes more thyroid hormones than your body needs, also known as thyrotoxicosis. So when TH is too high, it is hyper. In order to understand why this happens, we also want to take a look into other lab measurements. So depending on the measurement of the radioactive iodine uptake, it depends on what type of hyperthyroidism a patient may have. So if a lot of radioactive iodine is taken from the body, it explains how the thyroid gland may be overproducing. Otherwise, a normal radioactive iodine uptake is 10 to 30%. So above 30% would be an elevated uptake. However, a low uptake of less than 10%, there might be an overproduction of thyroid hormone not related to the anatomy of the thyroid gland, but maybe related to another cause, which is important why we understand why iodine is important. So when there are thyroid hormones producing, it pulls the amount of iodine from the body to produce those hormones. Just reiterating what I mentioned before. So with elevated uptake, that would be primary hyperthyroidism. An example of the cause of that would be Graves' disease or toxic adenoma. On the other hand, the opposite, where there's a reduced uptake or no uptake, would be secondary hyperthyroidism due to amiodarone toxicity, another medication toxicity, or postpartum thyroiditis. Some signs and symptoms to consider or looking for hyperthyroidism would be the ones highlighted here in the table. So, such as hair loss, tachycardia at rest, hypertension. Another thing to look out for would be weight loss, heat intolerance, increased sweating, anxiety, difficulty sleeping. A thing that I did not highlight in the table, but it is on the right-hand image, would be the bulging eyes, also known as exophthalmos. It is a hallmark sign of Graves' disease, but it can also be a sign of hyperthyroidism. It is known as the bulging eyes. And I did not want to traumatize you with a picture of bulging eyes in humans because it is pretty gross, and most of the time they're also red and inflamed. So the closest example that I thought of were those big bug-eyed chihuahuas. And some complications of this would be the eyes feeling dry and itchy, as well as sensitive to light. So normally when the T4 and the T3 hormone levels are elevated, it signals the hypothalamus to stop secreting TSH. So it would stop it around here and here. These blue arrows indicate the negative feedback loop. However, the loop is not working properly, which leads to continued production of these hormones, leading to elevated levels. So in this table, I noted the biochemical evaluation, so the hormones on the bottom two, and the TSH. Normally, I included the range that are highlighted here. However, please note that institutions, they may differ in their normal ranges. So please do not memorize these, but just make sure that you have a understanding of a nice range. I would rather have you understand what is elevated and what is not. So typically for hyperthyroidism, the hormones are high. So the T4 and the T3 are elevated, and the TSH is low. So for goals of treatment in hyperthyroidism, we want to make sure that the patient is euthyroid as quickly and safely as possible. And if it does not happen safely, it can render the possibility of the patient switching to the opposite problem, so that would be hypothyroidism. Between hypo and hyperthyroidism, one condition is not necessarily worse or more dangerous than the other. However, hypothyroidism tends to be easier to treat and causes fewer long-term health problems compared to hyperthyroidism. So please just note that there is not one more dangerous than the other, but they are both very important to treat. Another goal would be minimizing symptoms of hyperthyroidism that we mentioned prior. So in order to treat hyperthyroidism, there are a few treatment options that we will talk about. So there would be the thyroidectomy, RAI therapy, anti-thyroid medications, and supportive therapy. So what is a thyroidectomy? It is a surgery where we would remove all or parts of the thyroid gland that is located at the base of the neck. And how it is prepared is the patient would have to take iodines or anti-thyroid medications or any supportive medications in order to achieve that euthyroid state by the time of surgery. And why is it important to achieve that euthyroid state? Well, we would like to avoid precipitating thyroid storm or any other comorbidities that the patient may lead to. This is not a very common treatment modality, but more of a last option. It is also preferred in the patient populations highlighted below. So for pregnant females who are drug intolerant during their second trimesters, any patients who have obstructive symptoms that are present, or any patients who have a malignancy. An additional treatment option for hyperthyroidism would be radioactive iodine. So just as a friendly reminder, iodine is that important component in creating thyroid hormones, specifically more so for T4. And our main source of iodine comes from our diet, specifically seafood, eggs, or milk. And then 70% of the iodine is stored in the thyroid gland. So if we are giving a patient radioactive iodine, the radioactive iodine is going to be absorbed from the thyroid gland. Due to getting absorbed, it will destroy the thyroid gland by emitting beta waves and rays that cause definite local damage. So in order to have this work, what happens is the patient ingests the capsule with said radioactive isotype. The radioactive iodine is then absorbed via the stomach wall and into the bloodstream. The thyroid gland then soaks in any remaining iodine needed to function and create those thyroid hormones and absorbs some of the radioactive iodine. And then the radiation kicks in via its mechanism of action and destroys that thyroid gland. It is a more common treatment modality and is more preferred in the following patient populations. So more so for patients who are debilitated, who have cardiac comorbidities, patients who are elderly or who can't do the surgical option, patients who failed treatment of anti-thyroid hormone, and then patients who are contraindicated to any other options or have recurrent hyperthyroidism after surgery. Another treatment modality for hyperthyroidism would be the anti-thyroid medications. So one of the classes is called thiamides. There are two of them in this class, methimazole, also known as Tapazole or MMI, and the other one is propylthiouracil or PTU. They have a similar mechanism of action of inhibiting the action of TPO, which leads to the blocking of thyroid hormone synthesis overall. Otherwise, PTU has an additional mechanism where it also inhibits the peripheral activity of the T4 converting to active T3 form. So in order to kind of memorize this, PTU starts with P and it also works peripherally as in P. Some differences to highlight between these two because they are in the same class. For methimazole or MMI, it is preferred in second and third trimesters of pregnancies. Additionally, does have allergic reactions more so compared to the PTU, whereas PTU, it doesn't have as many allergic reactions. However, it does have a hepatitis adverse effect profile, highlighted in a few studies, and then it is more preferred for the first trimester of pregnancy. It is also reserved for thyroid storm due to its additional mechanism of blocking the peripheral conversion of T4 to T3. Regarding the thioamide class, for PTU and MMI, they both come in a tablet form. For PTU and for MMI, they both have an initial and a maintenance regimen. So we always want to start low and then slowly creep up depending on our levels and labs of our thyroid hormones. As mentioned before, for PTU, we're highlighting that it is more common and more prevalent of having hepatitis or hepatic adverse effects. Additionally, it may lead to a skin rash, more of GI upset between the two, and then agranulocytosis, more so in the PTU compared to the MMI. For the MMI, it is similar to the adverse effects listed above. However, it can lead to that embryopathy syndrome in pregnancy, and that is why it's not preferred in the first trimester. And this adverse effect is also seen in warfarin-exposed babies as well. Regarding PTU pearls, it is more preferred, as mentioned, in the first trimester of pregnancy. It does have a really intense bitter taste, especially when patients kind of chew on it. So that is something that we would like to highlight whenever we're counseling a patient. Additionally, tablets may be compounded into suppositories or enemas for needed thyroid storm treatment. Regarding for MMI, it is preferred in that second or third trimester of pregnancy. Overall, with this class, we would like to continue therapy for at least 12 to 18 months or until we have that remission achieved regarding the thyroid hormones. Another antithyroid medication class would be the iodines. This includes 5% iodine with or without the 10% potassium aspect added into this. It is more so known as an adjunct therapy, so something to be added onto. It is not supposed to be monotherapy. How this works, it has a dual mechanism of action. So there's a short-term effect where it temporarily inhibits the thyroid hormone synthesis and secretion back into the serum or the circulation of the body. Otherwise, there is a long-term effect known as Wolff-Chaikoff effect. And that is when the body is exposed to high levels of iodine all at once. It will downregulate the production of thyroid hormones overall, just as a protective mechanism. So this decrease is usually temporary, and it's meant to prevent any excess thyroid hormone levels, which can be harmful to a patient. But with patients with autoimmune dysfunctions or autoimmune thyroiditis, they may fail to adapt to that drop in the thyroid hormones and become hypothyroid, so the opposite problem. Some indications for this therapy would include thyroid storm, Graves' disease, thyroidectomy preparation, or thyroid gland protection post-RAI. Going a little into depth with this medication, there are two main drug names and drug forms. So one of them is Lugol solution, which includes the both iodine and potassium iodine solutions, and then another one just includes the potassium iodide, also known as SSKI. Regarding both of these, they are administered via drops, and they should be diluted in a glass full of water, juice, or milk, whatever the patient prefers. So just make sure you counsel the patient on this. And regarding if it is taken prior to surgery or for thyroid storm, just make sure you look up the specific amount of drops that are needed. Additionally, for adverse effects, it can lead to mucous membrane ulcers whenever they are ingesting this. They may also get hypersensitivity reactions as well as anaphylaxis if something is really severe. When the patient is ingesting this, they may notice that they have a metallic taste as well, so just warn them prior to if you do remember so. When patients are taking anti-thyroid medications, it is very important to monitor their levels of thyroid hormone, so T4 and T3 as well as TSH. But a side note is that for TSH, it may remain suppressed for several months after initiating therapy, so it is not always a good parameter in the early course. Regarding initiations or adjustments to therapy, we want to make sure that we're monitoring their levels every 6 to 8 weeks or so, or as directed by their healthcare provider. And then once a patient is more stable, the thyroid levels will be monitored every 3 to 6 months or as directed by their healthcare provider. As mentioned before, regarding PTU with that hepatitis, liver function toxicity, we are making sure that we are assessing that in the hospital. So especially when they're taking that PTU, who experience any pruritic rash, jaundice, anorexia, or any abdominal pain as well. And then another type of pharmacotherapy for hyperthyroidism would be their supportive medications regarding their symptoms. So the biggest class to help with the adrenergic symptoms would be beta blockers, specifically propranolol, and that would relieve those symptoms while awaiting the onset of the start of antithyroid medications and or RAI for thyroid toxicosis or that thyroid storm. If patients are not able to take beta blockers or are contraindicated to it, we can start them on calcium channel blockers such as diltiazem. And then any corticosteroid indications would be for patients who have thyroid storm, who have pretreatment prior to RAI therapy with those who have those bulging eyes. So why are we mainly focusing on beta adrenergics such as beta blockers for symptomatic relief? So in patients with high thyroid levels, there's an increase in the number of beta adrenergic receptors overall, and this could lead to those hyperthyroid symptoms that we mentioned, such as tachycardia, and those thyrotoxic symptoms mimic sympathetic overactivity. And in patients who have that sympathetic overactivity, normally would take beta blockers if it is a cardiac problem. And in patients who have the elevated thyroid levels, we can add on those beta blockers that can mimic those same effects. And specifically, we want to look at propranolol and migdalol that are preferred due to their additional mechanism of inhibiting peripheral conversion of T4 to T3. However, those thyroid function tests are generally not going to lower over time overall. It's just an additional effect. And the current guidelines also highlight how these are also preferred agents in the elderly, those who have heart diseases, and those who have heart rates above 90 beats per minute. So going into the serious sides of the hyperthyroid dysfunction, if it is not treated well, it can lead to thyroid storm, which is a life-threatening decompensation of hyperthyroidism. And it is due to numerous etiologies, such as stress of surgery, any thyroid manipulations, RAI, infections, non-adherence to their antithyroid medications, and more. This is pretty rare, but it does develop in patients who are hyperthyroidism, and it is diagnosed via Birch-Rutkovsky's point scale, or BWPS system, based on severity of individual manifestations. The BWPS system, I highlighted a table here in which it's just an example of what is included whenever we are assessing patients with possible thyroid storm, especially whenever we have patients in the ICU. So some things to look into is the temperature, how it's elevated, if they have any cardiovascular symptoms such as arrhythmias, if they have any hepatic dysfunctions, any central nervous system disturbances, and then any history status of their thyroid storm or thyroid hormone levels elevated. So as we are assessing the patient and adding up these scores, if they total anything above 45, that does precipitate the patient having thyroid storm. However, if the score totals anything less than 25, it is unlikely and the patient may just be experiencing mild symptoms or some other etiology. Regarding the thyroid storm signs and symptoms, it is similar to thyrotoxicosis, but it can be decompensated. So when we're thinking of heat intolerance, that temperature skyrockets even more. Additionally, tachycardia is precipitated. They may lead to a coma. They may have those bulging eyes as stated previously. Profuse sweating, tachypnea, and then any nervous system effects such as agitation, delirium, and psychosis. In order to manage this thyroid storm, we want to do it as safely and quickly as we can. So some of the goals, we want to inhibit that thyroid hormone release peripherally as well and reverse any systemic decompensation. In order to do this, we're adding additional treatments instead of just anything monotherapy. So one of the treatments would be the antithyroid medication or the PTU or MMI that we learned about. Inorganic iodide therapy such as the Lugol solution, any beta blocker or calcium channel blocker for systemic relief, and then systemic steroids as well as aggressive cooling, which can be done a little quickly with Tylenol, blankets, as well as hydration. So something to help you memorize this, and what helps me whenever I do see this, I remember this as the 4 P's. So one of the P's would be the PTU, another P would be for the potassium iodide, another P would be for the propranolol regarding beta blockers, and then the last PTU would be for the systemic steroid or prednisone. Additionally, we want to administer the antithyroid medication a little over an hour prior to iodide therapy, just to make sure that we're blocking the production of more thyroid hormones, since we are adding that PTU additional peripheral mechanism of action as well. So this is a good time to pause the PowerPoint presentation if you do need a break. Otherwise, you could continue watching this video on double speed. It is totally your call. But let's now transition to the hypothyroid state. I also included hypothyroid guidelines just as an optional reading or a reference for you in the future. And in order to remember what hypothyroidism is, it's just when the thyroid hormones are too low, so the opposite of what we just talked about. So low for hypothyroidism. Some factors that can lead to hypothyroidism would be Hashimoto's disease, and then any medications like amiodarone, lithium, or carbamazepine. For hypothyroidism, it is the opposite, like I mentioned, of hyperthyroidism. So we're seeing a lot of dry skin, bradycardia at rest, thick skin, weight gain, cold intolerance, extreme fatigue, and then a thick tongue. There are additional signs and symptoms that are highlighted on the right here with this image as well. And then for the objective findings, so the thyroid producing insufficient amounts of the thyroid hormones, which leads to the loss of negative feedback inhibition, and then that increases the production of TSH from that anterior pituitary gland. And please note again that the normal ranges may differ between the institutions depending on what the site has for their assay. But the main thing that I want you to remember here is that the thyroid hormones are low and then the TSH is high, trying to compensate for the low thyroid hormones. The goals of treatment for hypothyroidism is very similar to hyperthyroidism, in which we want to quickly and safely achieve thyroid as possible. We also want to minimize the symptoms of hypothyroidism and then avoid overtreatment, which could lead to hyperthyroidism. There are fewer treatment options, but they are more studied compared to the other state. So one of the treatment options is thyroid hormone medications and then supportive therapy. One of the thyroid hormone medications is levothyroxine, also known as Synthroid, Levoxyl, and Unithroid. It comes and is formulated to act as a T4 hormone that is synthetic. It's unique in its dosing because it is weight-based, so we want to look at 1.6 micrograms per kilogram per day. However, we want to dose it in a smaller fraction for patients who have known cardiac artery diseases, and then for patients who are pregnant, they might require an increase in their dose, especially in the first trimester, given the physiological explanation of their increase in thyroid hormone requirements due to their high estrogen levels, as well as increased volume of distribution. Levothyroxine comes in multiple drug formulations, so not only PO formulations, but also injectables. Regarding those PO formulations, make sure you're counseling patients to have them take it with water at least 30 to 60 minutes prior to breakfast, or 3 hours after dinner, just to make sure that their absorption is maximized. Whenever we are thinking about PO to IV or IV to PO, there is a specific ratio of 0.75 of IV is similar to 1 of PO, and that just means that the bioavailability is not 100%. Additionally, levothyroxine has major drug interactions just because it is highly protein bound, and it is a more potent formulation due to it being synthetic, but also compared to its natural formulation. And a unique aspect is its long half-life of 6 to 7 days. So in the guidelines, it is also highlighted and noted that given its long half-life, patients can safely be advised to make up for any omitted doses. And the best thing a patient can do is take a weekly pill box just to make sure it's helpful for identifying any omitted doses. As mentioned before, levothyroxine has many potential drug-drug interactions. So some examples here might be it having a reduced absorption, so not getting as much into the body due to anything that is chelating, such as iron, calcium carbonate, aluminum, iodine, selenium, magnesium, and antacids. It can lead to an increased clearance, so again, not being as much in the body due to phenytoin, carbamazepine, phenobarbital, rifampicin. And it can also be increased in the body due to estrogen hormone replacement therapy. A little side note here, just focusing more on the NAPLEX side of things. Levothyroxine, whether it's coming from a generic or brand formulation, they all come in specific strengths that are specific to its colors. And I just highlighted the colors here on the right. And a great mnemonic to have memorized would be only white violets or yellow roses bring teachers back looking pretty glad. Just a side note, I did have a few questions from the NAPLEX regarding the colors, which was a very niche topic. So if that is something that you could try to memorize in your head as best as you can, I just wanted to provide you with something that would help. Another thyroid hormone medication is thyroid desiccated USP, also known as Armour thyroid and Nature thyroid. This is a natural thyroid hormone, and the earliest formulations of it actually came from the thyroid glands of cows. However, in the 1900s, the meat companies got into the medication arena, and they started marketing its own natural desiccated thyroid from their pigs, and now it's known as that Armour thyroid. So now all commercial thyroid desiccated USPs are actually coming from the pigs. So the dose is highlighted here on the left with its initial maintenance. It comes in tablet formulations in multiple concentrations, which is nice whenever we want to start titrating the patient by increasing it with 15 milligram increments. A pearl that was highlighted was that the brand Armour is actually preferred over the Nature thyroid or its generic formulation. It is not very predictable regarding how much of the T4 and T3 ratio is in there. So it does include both thyroid hormones, but we do not have enough studies to include how much is in each tablet. The half-life is very similar to levothyroxine, and the onset is 3 to 5 days. Another class of thyroid hormone medications is liothyronine, also known as Cytomel or Triostat. This is another synthetic hormone, but specifically a T3 hormone. It is another non-weight-based dosing of micrograms, 25 micrograms daily, and is also titrated by 12.5 to 25 microgram increments until you reach a maintenance dose. It comes in both a tablet and injectable formulation with multiple concentrations of the liothyronine. Some pearls to highlight is that it does require multiple daily dosing. So if we look at the right of the half-life, it is a half-life of 0.75 days. So in order to have the patient continuously produce that T3 hormone, we want to make sure that that patient is not going to drop out of their steady state, but to continuously get that steady state over. Again, just noting that another unique aspect of this medication is its cardiovascular adverse effects. So that would include heart failure, any cardiac arrhythmias, MIs, or tachycardias, which is kind of why it is falling out of favor compared to levothyroxine. However, a great thing is that it has complete absorption whenever it is taken. Overall, with these thyroid hormone medications, like for hyperthyroidism, we want to monitor how much is getting in the system. And we do that with the T4, T3, and TSH levels. So whenever patients are getting initiated or are adjusting their therapies, we want to monitor every 6 to 8 weeks or as directed with their healthcare provider. And once a patient is stabilized, we want to monitor them every 6 to 12 months or as directed by their healthcare provider. Additional considerations, as we highlighted prior to, is those possible cardiac symptoms with those thyroid medications. So I only highlighted the cardiovascular problems in the liothyronine. However, there's more that comes into effect with these hormone medications. So overall, if there is a hyperthyroid symptom and if it's overcorrected going towards that hypothyroid state, we're looking at hypothyroid symptoms like tachycardia, palpitations, weight loss, arrhythmias, or irritability. Additionally, there may be possible cardiovascular diseases, but that's mainly seen with the liothyronine. And then the thyroid desiccated USP, or that natural thyroid medication, it can lead to allergic reactions due to it being made out of that animal protein, and possible mild thyrotoxic symptoms as well. Just because the ratio of T4 to T3 is lower than a human ratio of 14 to 1, so that may exacerbate increasing the amount of thyroid hormone in the body and with unknown absorption. So if a patient is hypothyroid and they're not getting the correct treatment or having any exposures to other comorbidities, it can lead to a life-threatening decompensation of hypothyroidism, also known as myxedema coma. And some factors that could lead to this would be infection, exposure to cold temperatures, trauma, respiratory acidosis. This mortality rate for myxedema coma is pretty high, especially compared to that thyroid storm. So it is 60 to 70%, and it is higher, especially in patients who are older aged, cardiac complications, who are taking a lot of T4 and a lot of T3. And it's typically just based on physical examination and exclusions of other causes of coma. Big thing here to look at would be the cold intolerance, bradycardia. A physical marker would be the goiter, menorrhea, hyponatremia as a laboratory marker, and then memory and mental impairments as well. In order to helpfully manage this myxedema coma, we want to make sure that their thyroid hormones are getting replaced and that they are getting maintenance of vital functions as well. So in order to treat this, we want to go as quickly as possible, but also safely as possible as well. So in order to do this, we're giving them IV thyroid hormone medications. So we want to give them both levothyroxine and liothyronine, that T4 and T3, which is recommended on top of stress dose steroids such as hydrocortisone as an example, and as well as supportive measures. So mechanical ventilations if they are not able to produce enough oxygen, any fluids as needed, rewarming but not as fast as cooling, and then arrhythmia monitoring as well. If the patient becomes a little more stable over time, we can think about changing their oral dose to something more appropriate compared to their IV formulation, so make sure to remember that conversion. So you made it after talking through hyper and hypothyroid states, so thank you for that. Just a reminder, make sure you're filling out or have already filled out that assigned worksheet. That would be amazing. It is due on the 27th, but in the morning prior to our lecture, just making sure that you are getting the participation credit of this pre-assigned work. If you do have any questions and you can't find the answer after looking them up, don't hesitate to reach out to me. I did include my email here. And then be prepared to jump into case questions when we are in class, like I mentioned before, to drill some of this information down prior to your exam on Friday. Thank you all so much, and here are my resources. Thank you so much. See you soon.